Hello, everyone. This is Sherry Boehringer. I'm an associate editor for Prescriber's Letter and Pharmacist Letter. For this set of recommendations, we'll be discussing drug interactions with grapefruit. Here to help us with these recommendations, we have Dr. Phil Gregory, our editor of our Natural Medicines Comprehensive Database, as well as Dr. George Dresser from the University of Western Ontario. In fact, Dr. Dresser and his colleagues recently wrote a paper identifying more drugs that interact with grapefruit. And this paper actually got lots of attention, including by the lay press throughout North America. So we knew that it was important for us to write about this because clinicians and patients would be having lots of questions. So my first question is about grapefruit permanently inactivating cytochrome 3A4 enzymes in the gut. And my question about this is, and Phil or Dr. Dresser, either one of you jump in, does grapefruit inactivate 3A4 in the liver too? And the reason why this question is coming up is because if it does, would grapefruit also affect drugs that are given IV?
So the issue around 3A4, it really is a gut-only effect. There has been a study showing that consumption of very large amounts of juice, I think up to about 2 to 3 liters of juice, can have a small effect on liver 3A. But it was in the order of there was about a 10% change in AUC for administered drugs, sort of intravenously administered drugs, which wasn't enough to be clinically relevant. So I really think the grapefruit juice effect should be considered to be a gut-only and relevant for orally administered drugs, but not intravenously administered drugs.
Okay, well, very good. Thank you for helping us with that question, because I'll tell you in some of our previous webinars and conference calls, we've gone round and round about that. So thanks for your help with that. Go ahead,
Sherry. There is also some other, there's reasons to speculate that there might be some hepatic involvement. And that's because there's, some data showing that, back-to-back or daily consumption also could get the hepatic enzymes more involved.
I see.
And so you might see an increased peak with the first dose, which would suggest gut only. But with the second and third and fourth and fifth daily doses, then you start to get an increased half-life. At least this has been seen in some, preliminary data. So I think that might be the reason why there's some confusion out there, because many of the studies seem to only show a gut effect, and they're usually or often single-dose studies. But with repeated administration day to day, it may involve hepatic enzymes too.
And I just wonder, practically speaking, there must be a dose dependence to this interaction. The labeling for Zocor says a quart of grapefruit juice.
Yeah, I was wondering about that too.
So I personally think that the labeling for Zocor is misleading. There are studies showing that 250 milliliters is enough to cause more than a doubling in the concentration of the active simvastatin acid. If you believe that the dose dependency is important enough that we ought not to be giving the 80 milligram dose of simvastatin, then even a doubling of the level is probably enough. The study that Merck did gave a larger volume of juice in the morning and then dosed the Zocor, which they appropriately, said, well, Zocor is supposed to be given in the evening, so we'll separate it by 12 hours. And when you separated by 12 hours, that's when they were able to show a doubling of the level after 12 hours. But when you give it actually at the same time, you can see up to a 20-fold increase in the inherent
That's pretty scary, given the information.
We have an audience question coming in that someone asks questions about this. If a patient has an occasional grapefruit, is this okay? Or do they need to avoid grapefruit altogether? And in other words, how often do they need to consume grapefruit for it to be a concern?
So there's two possible answers to this. The first thing I would say is that it very much depends on what drugs the patient is taking. In most cases, if you look carefully at the drugs and you look carefully at why they're taking it and what the therapeutic index is, many patients can get away with small amounts of grapefruit juice, especially if you separate the timing of the grapefruit juice from when they take their medications. The trouble is that patients who take medications invariably end up at some point in time being on a medication where having the correct level of drug getting into them will help with predictability of the effect of that drug. And if the patient gets used to consuming grapefruit or grapefruit juice, then they at some point may be given something by a prescriber or practitioner who doesn't know that they consume grapefruit and doesn't ask the question. And so I think in general, if you have a patient who requires medication on a regular basis, I think it might be safest to tell them to try a different citrus. But in many cases, the characteristics of a drug which interact are very low bioavailability drugs that are metabolized by 3A4. So, you know, if the patient really wants it, you look at the drugs. If they're on a drug like amlodipine, which is 3A4 metabolized but has very good bioavailability, I would have absolutely no concerns about using that drug with grapefruit. But if they're on felodipine, which has a low bioavailability and is also metabolized by 3A4, then I wouldn't want them using it. So I think you can go drug by drug, look over their drug list, and if they're not on any of the drugs that have a high interaction potential, well then sure, that they should be able to consume grapefruit if it's important to them.
I just wanted to add one quick comment that the other thing we have to do is, in addition to go drug by drug, which I know is a lot of work, but we also have to go, to some extent, patient by patient, because different people respond differently, and there can be substantial variation in 3A4 response between groups of people and individuals. So I think it can be hard to predict where we might say it's totally fine for a large group of people if, you know, eating a little juice or drinking a little juice, but for others it may not be so fine.
Right. Okay.
I completely agree. And I mean, in my practice, if I get the question, usually my pat response is just don't do it. And I think I haven't met a patient yet who, and I get people sent to me for this, who isn't willing to try something else for their diet. You know, I understand that grapefruit is popular in some demographics, but I think as a general rule, for those of us who are interacting with patients, we ought to simply tell them to avoid it.
Someone's asking, what other fruits might cause a similar reaction?
Yeah.
Right, so there's no problem with lemons. With lime, certainly it's a fairly large amount of lime required. We did that study. And it was difficult to get the study subjects to consume enough of the lime juice to cause the interaction. The level of I think I can't remember the exact percentage lime juice that was in the drink that they had, but it was in the order of 25%. The interaction potential for lime is certainly less than it is for grapefruit, so that if lime is being used as a flavoring in very small amounts, I think that again, an interaction is a lot less likely than it is with grapefruit juice. The same is true with Seville oranges, which are the oranges used to make marmalade. Because they're very potent in taste, I think it's unlikely that someone would be exposed to enough of it to cause an interaction to the same degree as grapefruit juice. But a lot is unknown.
Thanks so much, Drs. Dresser, Gregory, and other panelists for your help revising these recommendations about grapefruit interactions and for providing us with tips on how to handle grapefruit interactions in practice.